going to briefly introduce, we have Victoria Ferrara from Worldwide Surrogacy. Dr. Kaufmann, Victoria is going to speak about the overview of the surrogacy agency process. Dr. Kaufmann is going to handle part of the medical aspect, optimized embryo creation through screening fathers and egg donors. We have second Dr. Brandon Bankowski. He's going to be speaking to screening and matching with surrogates. Did we not have a chair for you? Oh my God, I'm so sorry. And he's going to talk about screening and matching with surrogates and treatment stages. Then Meryl Rosenberg, who is an attorney, who's going to be speaking about the legal aspects of the surrogacy journey. And finally, our very own board member, Gregory Payton, who's going to talk about the psychological aspects.
A lot of us are good at what we do, so you need to find the people that you want to work with who will be your professional team. And your agency should really be steering the ship regarding finding a qualified surrogate and then processing the surrogate and also helping you through the pregnancy. So, for example, at our agency, we do the screening of the surrogate before you even meet your surrogate. And screening, you should find out what the screening protocol is at the agency. So we will do a psychological evaluation, including a MMPI standardized test. We'll do a medical records check. We'll do a background investigation of the surrogate and her husband if she's married, and also a social worker intake. We have a social worker on staff. That's Jen MacArthur, who's with me today. And we also have a surrogate who was a woman who was a surrogate who helps with the recruiting. So the agency should have people who have know-how, practical experience in surrogacy, and preferably do all of that screening ahead of time. And many of the agencies do this, so there are different places where you can be in good hands. Then the other thing is you want to find out who your point people are going to be at the agency and make sure that you have good access to them and they respond to you. You want to find out how you're going to meet your surrogate. You want to find out if the agency has good experience with the medical clinic so that they will team up with your medical clinic in a very effective and positive way and help you with all of that coordination. So if you're paying an agency, that agency should help you to coordinate with the clinic and take that off your shoulders. You should enjoy the surrogacy process. The one drawback of surrogacy is it's expensive. You should be able to enjoy the process. You should be able to enjoy the relationship with your surrogate. You should be able to be excited about having a baby. You shouldn't be bogged down with the details of money issues or contractual problems. There shouldn't be contractual problems. If your agency is finding a qualified surrogate, this is going to be a woman who's dedicated to carrying a baby for you. She is going to be sound, stable, willing to do this, happy to be pregnant, excited to help you have a baby. So it should all be a positive experience, and that's the kind of vibe you want to get from your agency. Is you want a positive vibe, you want people who are going to be working for you, who are committed, dedicated. Then you have a pregnancy. You want the agency to help you through the pregnancy in certain really important ways. Legal. Attorney Rosenberg will speak more about legal. But the agency should be there for you. They should either be having a lawyer on board who can do the legal, or they should outsource the legal and then oversee it to make sure it gets done. So if the baby's being born in Illinois, the surrogacy agency should be able to refer you to qualified attorneys in Illinois and then outsource it in a way that the local lawyers are like local counsel and the agency is like general counsel, making sure the job gets done. So you should be able to go to your agency and say, how's my pre-birth order going? Can you find out about the parentage work? Do you know these lawyers? And then, of course, if you're going to be at a hospital in a different state from where your agency is, the agency should communicate with the hospital and let the hospital personnel and staff know what's going on. So this agency should be really the center of the process. Well, you are the center. You're having the baby. Your surrogate is at the center with you. You are the nucleus. No pun intended, nucleus egg. You are the nucleus, you are the center of bringing the baby into the world. Around you is your professional team, the agency, the lawyer at the agency, the staff at the agency, the medical clinic, the doctor, the staff at the clinic. This is one team. We are all getting together to help to bring this baby into the world, so you're going to have the wonderful family that you're dreaming of. So look for qualified people, look for people who are going to do what they say they're going to do, and who are going to be really responsive and dedicated to you. Thank you.
So anyway, this is the objective right here. These are embryos. I don't really have a pointer, but that's okay. What you got around the outside is what we call the trophectoderm, which will be the placenta. A little round thing in there is the inner cell mass, which is going to be the baby, and there's fluid around it. So this is like, that fluid's like the bag of water when somebody breaks their bag of water. So this is kind of the goal, at least from the fertility clinic. And how do we get there? Is that sperm. It's a lot of sperm looking for that egg. I'm going to talk a little bit about the sperm. That's an egg, microscopic. You can't even see it with the naked eye. And that's that sperm trying to dig into that egg. So let's talk about the sperm. What we have are a situation where your surrogate is going to get donated tissue. It's going to be a sperm and an egg, and we'll talk about each. Typically what happens, at least at our clinic, as most clinics, what I would advise you do is probably in the beginning of the whole thing is get a semen analysis done. I had an IP once that came from Louisiana, no sperm, devastating. So at least before you start this journey, I would strongly recommend you get a semen analysis. Your primary care doc can do it. Anyway, there are a host of ways to do that, and I would strongly recommend that. As far as the sperm is concerned, what we typically do is have our intended parents come down to our center. We talk to them further. We'll freeze the sperm. That way, you don't need to come to your clinic where it happens to be. If it's in New York, that's easy. But most of our patients are not from Fort Worth. You can freeze the sperm, and the FDA has certain regulations where we need to check your blood work. So we need to check for HIV, hepatitis B, C, chlamydia, gonorrhea, and syphilis. Now, if any of those come back positive, you can still go through the journey, but then the surrogate needs to be informed that there might be a potential risk of transmission of a sexually transmittable disease, and she would need to sign off on that. So it's not a deal breaker. We deal with a number of couples that have HIV that go through, but that's kind of the initial part of it. There's a medical assessment, a physical assessment we need to do, because in the eyes of the government, they don't care if it's an egg, sperm, liver, eyeball. There's certain regulations in donated tissues that you need to undergo. And whether you use fresh or frozen sperm does not matter. You can take sperm, you can even inject it into the egg, which we commonly do. And there are a bunch of acronyms in our specialty. This is called intracytoplasmic sperm injection, which is ICSI, ICSI. So we can get around any sperm problem. And so going back to doing your semen analysis, even if you've got a low sperm count, no big deal. I've got a number of intended parents. They go, oh my God, my sperm count's low. I go, listen, not a problem. Just as long as you've got sperm, we can work with it. Things to consider, which is going to be really important when you're looking at the donor or the egg, is, is it one or two partners? Are we going to be splitting the eggs between two people? If that's the case, then you're probably going to want to look for a donor that's going to have more eggs, for example. Are you going to put back one or two embryos? And sometimes we'll have intended parents where one guy will say, okay, let's do the transfer on my embryos this time. The next journey, we'll work on my partner. Main thing here is to understand that you are in control of how you want this to go, and it's important that you communicate with your clinic on exactly what you want. And again, you are in charge. This is a big deal, and you should get what you want. Eggs. So sources, you heard a little bit, some of these introductions, you can use it fresh or frozen. A lot of the clinics at agency have a high selection of donors you can choose from. You can use frozen. It appears that using frozen eggs versus fresh eggs, very similar success rates, and we have found that true. One of the limitations you do have with frozen is the number of eggs you may be able to get. So in other words, you might spend $10,000 for 6 eggs, for example. If you get a fresh donor, you'll get a whole bunch more. So I think if I've got a single intended parent, frozen eggs, I think, will work very well with them. Typically, you'll have about 2 embryos in that situation to work with. You can put 1 or 2 embryos, that works well. But especially if you get a couple and both you guys want to go through it, and if you even have a gender preference from doing pre-implantation genetic screening, that may not suit things as well as using a fresh. So these are typical things that you need to kind of keep in mind. And I really do think the donor, that decision is going to be probably your most important one. Now, certainly, if you're with one of these wonderful agencies we have here, they'll find an excellent surrogate for you. They're going to do a great job, but ultimately you're going to have this person, which is going to be a combination of yourself and the egg. So very important to choose the right donor. Screening, there's a lot of screening that goes on behind the scenes that you're not familiar with. So for example, maybe for every 10 donors that we screen, probably one would be someone that would meet the characteristics of passing through to the second phase of evaluation. And of those, 1 out of 10, maybe 50% will not make it through. Maybe they have a low A count, their infectious disease panel is abnormal, and so by the time you're actually looking at a lot of these donors, they've already been screened. So you look at ages, for example, 21 to 31. It depends on what agency you look at. It seems like the sweet spot from a genetic standpoint tends to be between 23 and 28. Not that a 22-year-old isn't going to do well or a 30-year-old, but looking at the genetics of these eggs, that seems to be the sweet spot for them. You're going to be looking at a profile. So what are you going to look at? You can look at their information. You can look at pictures of them, their history. Have they done a cycle before? Haven't they? There might be an advantage if you have a donor that's gone through a cycle. You'll know their history, how many eggs you got. But that's not to say you can't choose a donor that hasn't gone through before. When we've looked at our success rates for donors that have actually been first-time donors versus repetitive donors, there really hasn't been a statistical difference between success rates between those groups. But that's something you also want to take a look at when you're looking at these donors. It could be anonymous or known. If you want to have a relationship with the donor, you make it clear to the clinic or agency that you want to have a relationship with this donor down the road, or maybe you don't. Maybe you like to have it more, okay, listen, they don't need to know me, I don't want to know them, and you can proceed along those lines. Very difficult, I find, choosing the donor. I sometimes have couples that say, listen, I've narrowed it down to these 3 donors. Which ones do you choose? And I'll look and I'll go, whoa, I like this one a little better for this and this one for this. Again, it goes back to that subjectiveness I was talking to earlier, and you'll finally make a decision on who you want. And there might be a donor you go, oh my God, she is the best. And then you might have them evaluated by the doctor and they go, you know what? She might have less eggs than you would typically want for a donor. Then it's going to be up to you to decide the risk-reward with that, because I've had situations where I think this donor is going to have less eggs than average, and my intended parents go, you know what, I like the way she looks, I like her background, you know, I appreciate the advice that, or knowledge that we might have less eggs, but we're going to proceed. And it's generally not a situation where the clinic's going to say, no, you can't use her, unless, you know, we really feel super strong that it's just going to be not a good situation. But ultimately, again, you are in charge of your destiny. Donor screening, we check their ovaries, psychological screening, genetic screening, they'll see a genetic counselor. We'll do testing for cystic fibrosis, SMA, all these other genetic things. There are global tests that can check for hundreds of different genetic problems. We do a urine drug screen, a nicotine screen. So they are really screened very tightly, and they are also checked for infectious diseases that I mentioned to you earlier that you all would need to be checked for. A count, ultrasound, yeah, it's almost like opening a carton. We don't want any cracked eggs, you know. But we can look at ovaries and determine how many eggs are we going to find in those ovaries. So with about 80 to 90% predictability, we can look at ovaries, take our fertility crystal ball out and go, with this donor, we anticipate we're going to get these many eggs. It's expectations. So again, if you're a couple, you both want to use this donor, and if you, for example, have genetic preference for gender, then you're probably going to need a donor that's going to give you, I don't know, in my opinion, probably 20 or 30 eggs to work with. Because if we get 10 eggs, for example, we're probably going to end up with about 3 embryos. So you can do the math, 20 eggs, 6 embryos, and if you split it, there's 3 for both of you. And then if you do genetic screening, which is where you can actually take cells from the embryo and do an analysis on it, and what it checks would be your DNA. Now, you got to go back to your biology. I know that's hard, meiosis, mitosis. I hated it. Now it's my life. I'm a total geek. Now I just totally dig it. But you have 46 chromosomes, and it checks all the chromosomes. We went from analog to digital probably, 3 or 4 years ago, and now we can check all the chromosomes. Before it was 7 to 11. Very, very powerful tool, in my opinion. And what it'll do, you remove the cells, and the next day you can get the information on the genetics of the embryo. So here's an example of somebody that actually had 10 embryos. that is a lot. You know, if you do the math, what I talked about before, this person probably started with about 30 eggs, 10 embryos. And if you look over on the right, diagnosis, abnormal versus normal, you have 2 normal. This is a little unusual. If you have somebody, for example, that's young, a donor, typically 30 to 40% will be abnormal. And you can actually look at those embryos, and even in super duper hands, for example, my main embryologist done 30,000 cases, his eyesight's very good, and even with his knowledge and background, he can't predict which ones are genetically normal or not. So this situation actually had 10 beautiful embryos, 2 were normal, we put 2 in, and this person actually had twins. This was actually an OBGYN in our town. So, and they're XX, which means girl, XY is a boy. So if you do this and you have, for example, 5 embryos and you have a gender preference, certainly you can tell us what you want. Sometimes embryos look a little better than others, and you'll probably choose, we would counsel you if you put, I want 2 boys and they happen to be the stellar ones, you're probably looking at about 80% chance of getting pregnant with those. If you want 2 boys and 1 stellar and 1 so-so, maybe it's 70%, and that's a conversation you would have with your doctor as well. Some people want to be blinded for it. A lot of couples say, listen, whatever's going to give us the best chance of getting pregnant. And so again, it's communication with your doctor, your agencies, we talked about before, that's really important. But this is something that's not necessarily you got to do in your situation. However, I would say, especially with the surrogate journey, which is huge, I think there are some benefits from it. So thank you very much, and look forward to talking to you later.
And I've condensed my 3 hours of talks on these topics into the 8 minutes that they've given me. So I have essentially 2 options. One is to talk really, really quickly, and the other one is to hit the highlights. And I think we're just going to focus on the highlights. With regard to the screening of the surrogates, I think it's important that you understand that we have extensive lists of things we're looking at. The surrogacy requirements that my program has are 2 pages long, and I'm sure that other programs around have similar lists. However, we're looking at the general health, we're looking at how did the surrogates do in their past pregnancies, what is their social situation, what is their psychological evaluation show. So there is a lot that goes into making sure that a surrogate is a very good candidate. And again, everybody has the same goal in mind to lead to success. Now, in my experience with this, the one thing I would say is that I think it's most helpful if this screening is done before you match. And for example, if you were a lesbian couple that were going to pick a sperm donor, you wouldn't pick a profile and then do a semen analysis. It doesn't make sense to do it that way. So if you can be shown profiles that are already medically screened by the physicians that are helping you, and there's a lot of very qualified people in this room right here that will be helping you, that is going to be a big advantage. If that's not possible, it's still okay. It's just you meet the person, you get attached to the surrogate, and then we find in the records that maybe there's a problem or there was a complication or maybe they can't, they're not appropriate to carry twins. So that's important. And the other thing is that the physicians need all the records. In order to help you and utilize their expertise for you, they need to have all the records of all the pregnancies. To think about medical risks, one of the ways in which we're able to minimize the risks for the surrogate, for your babies, and for you during the process is to do testing. And we do a number of different tests. There's a standard set of infectious disease testing that all the surrogates have. We do obstetric clearance from their primary doctors oftentimes and general medical health screening. The surrogates go through psychological evaluation as well. And then the treating physician that's helping you should be the one to do very thorough uterine screening. Does the uterus look anatomically normal? Is there good uterine blood flow? Are we able to do a transfer easily? That's really, really important. And again, lots of help here. Now, the biggest way to minimize risk, I think every physician would agree, has to be, however, to try to minimize multiple pregnancies, to consider transferring just a single embryo, because everybody knows that twin pregnancies, triplet pregnancies, multiple pregnancies have tremendous risks. Now, full disclosure here, in my own IVF, I transferred 2 embryos and have twins from that, and I've been paying for it ever since. So, but medically, we certainly know that there are increased complications of women who are carrying multiples. There's a long list of those. It's a long conversation, but they include complications such as having high blood pressure during the pregnancy, having to be on bed rest because you have preterm labor, higher chances of having a C-section. And so that's something to discuss with the surrogate beforehand. The twin rates are very high in many programs. Our twin rates are 70% to 80%, and so it's something that's very, very important. I realize that that's a goal for a lot of people, but you have to understand that there are risks associated with that. To touch on coordination, I think that the resources that you have here are very experienced, and most of them have dedicated coordinators that will be helping you. You should have a strong relationship, a connection with those coordinators. You should be at peace and very comfortable with the process, know what's going on, know who's helping you, know who's going to help you with your genetic counseling or your psychologic evaluation or just the coordination of the cycle itself. Certainly, I think there are logistical advantages to doing it in one location where your clinic, your agency, your surrogate, your donor are all in a relatively close area. But a lot of cycles happen with people from all over the place. There's different trends that are happening in the field as well about fresh versus frozen cycles. Do you synchronize or not? And I think there are a lot of advantages if a program has a very good freezing program. There's a lot of advantages to not synchronizing. And by what I mean by that is not trying to line up the egg donor's menstrual cycle with that of the surrogate. And if you do that on a fresh cycle, the advantage is you don't have to freeze the embryos. But with very high vitrification rates, like a lot of the programs have now, you're able to dissociate those 2 cycles. And egg donors and surrogates are different demographics. Egg donors are usually in their 20s. Many of them are in school. Surrogates have had babies, so they're often young moms in their 30s, and they have different schedules, and to synchronize them is stressful for them. And if anything happens with either one of them, then the cycle has to be rescheduled, and it can take longer to do that. So the point about coordination is, number one, have a strong connection with your coordinators and the team that's helping you. And number 2, ask a lot of questions about how the particular agency likes to go forward. What are the risks of a fresh cycle? What are the risks of a frozen cycle? Now, success is a long conversation, and I just want to touch briefly on just a few elements of it. I grew up in Ohio, and my neighbor was 70 years old at the time, and his name was Bill. And Bill needed a quadruple bypass, which was a very big heart surgery. And we lived 20 minutes from a town called Akron and 20 minutes from a town called Cleveland. And he decided to go to Akron General Hospital, and he loved his doctor. He was very nice, and he had done one of these, I think, the month before. And he had a complication, and I was pretty young at the time, but thank goodness Bill was okay. Well, as I got older and got into medicine, I learned the Cleveland Clinic is essentially the top of the pyramid for heart care in the world. They have 50 cardiac operating rooms that operate every single day. And a lot of the research that came out of the Cleveland Clinic showed that in an experienced center with a higher volume that has a lot of different cases going through, and they're able to get data and do quality control, quality improvement, the outcomes are better. The Cleveland Clinic was actually instrumental in showing that. Now, he went to Akron General because he liked his doctor, and that's great. It's important to have a relationship with your doctor. But we have a lot of data now. We have a lot of outcome data. We are very fortunate in the United States to have something called SART, which is the Society of Assisted Reproductive Technology. And there's a voluntary national database where all of the reputable clinics will send all of their data. And so you can look at the success rates for IVF and donor egg and frozen cycles, and you can get a sense of what to expect, and you can evaluate a program. Very good programs should be very good at everything that they do, and you should see that over years as they present their data. There is big data out there. It exists. you are doing the most important thing right now, and that's you're collecting that data. You're learning things, you're seeing. And so doing your homework, I think, is a really important part of it. The most important thing for you is to have a good experience. Again, I agree with Victoria. You should enjoy this. You should be at peace with it. There's a lot of medical expertise and surrogacy agency expertise here to help you. And ask lots of questions. Ask your friends. Go on the blogs. Do your homework so that this ends up getting you to your dream in the most effective way. So, thank you so much for your time.
Thank you.